Welcome, everyone. My name is Brad Siff. I'm the founder and president of BioWave. I am very excited to introduce our guest lecturer this month. His name is Dan Bellamy, and he will be providing a lecture titled Pain and Performance, Using BioWave to Treat Pain in a High-Performance Sports Environment. Stay on afterwards. We will have a live Q&A session in about 20 minutes. And please use the Q&A box at the bottom of your screen to submit questions. So with that, I would like to introduce Dan.
Thank you. I'm really excited to dive into a topic that I'm very, very passionate about, and that's pain and performance and how we apply BioWave technology in the high-performance sport environment. So a little bit about myself. Again, I've been in the athletic training profession for over 15 years. I started my journey in athletic training at North Carolina Central University, small HBCU in Durham, North Carolina. I did my graduate studies at Cal UPA in performance enhancement and injury prevention. I was fortunate enough to do an NFL internship with the San Diego Chargers. My first job was as a head athletic trainer at a high school at Archbishop Carroll High School. While there, I was also working as a rehabilitation tech. And I also had the opportunity to be the head athletic trainer for an arena football program in DC. My first college job was as an assistant athletic trainer at Howard University. I worked men's basketball, men's soccer, track and field. I was then a director of sports medicine at Coppin State, which is in Baltimore, Maryland, where I worked men's basketball, men's track and field, and baseball. Transitioned shortly after that to be the director of sports medicine. And that's really where I got, through my journey, I developed a passion for collaboration and seeing really, really smart people come up with amazing ideas to enhance the student athlete experience and make sure that they perform well while keeping them healthy and just doing really, really interesting and cool things in the realm of human performance and health. So through that passion, I was able to become the director of sports performance at Howard University while I was overseeing football and men's and women's tennis. I also oversaw the mental health department, the sports psychologist and neuropsychologist that we had there, psychotherapist, that we had there, the nutrition initiatives, as well as the strength and conditioning department. So I got to put together a team that worked really, really efficiently together in order to not just enhance the medical aspect of things, but the sports performance aspect of things as well. Which then led me to the opportunity I have here at University of Texas San Antonio, where I'm the associate AD for sports medicine, where I oversee all administrative aspects of sports medicine here at UTSA. I oversee football, oversee men's and women's golf as well, and continue to build tight collaborations and initiatives with our sports performance professionals and some of the other stakeholders that I'm going to talk about later. So for me, from a philosophical standpoint, whenever we introduce technology into the athletic training room, it needs to be three things. It needs to be effective at what it claims to do. It needs to be efficient, it needs to be easy to use and easy to apply. And it also needs to be adaptive because we're always moving. It's a very fast-paced environment. So it needs to be a technology that's very, very adaptive. So overview, I'm going to go through sort of our philosophy at UTSA, how that fits with the BioWave technology, our typical applications, and then a few specific case studies where I'll start off with some pretty basic case study and then move to some more complex applications that we've tried to use. So just a little background on what I mean when we say the high performance sport environment. That's a collaborative environment that combines the expertise of medical providers, sports performance professionals, educators, and researchers to maximize health, wellness, and athletic performance. And that's a mouthful. But again, it's essentially an environment where all of these people, we leverage their expertise and make sure that we communicate, share information, share data, collaborate around some common objectives to ultimately make for the best experience for the student athlete. And as you see, this is sort of our high performance sport pyramid. And while everybody sees on Saturday, you see the skill and execution of our athletes on a Saturday or on a game day or on the golf course or on the soccer field or wherever they're playing. There's a lot of work and there's a lot of initiatives behind the scenes that help to make that, get those things to come to fruition. So obviously at the foundation of everything that we do from a performance standpoint is function and health. We want functioning, healthy athletes. Our strength and conditioning professionals are some of our greatest partners in that, in making sure that student athletes are robust and adaptable and resilient, while also making sure that they're safe. But they also help make sure that student athletes have the performance capacity to execute the skills and the strategies that they're asked to accommodate on the field of play. So when it comes to our philosophy around patient care, we've been trying to develop this philosophy with our strength and conditioning professionals and other allied healthcare professionals and researchers that we like to call the Roadrunner pathway, or we just say the way sometimes for any of you Star Wars fans out there. It's essentially our approach to injury prevention, performance enhancement, and patient care for elite level athletes, because we do want to treat them like elite level athletes, because they constitute a very small percentage of athletic populations. Their ADLs are different. Their activities of daily living, what they're going to be asked to do on a daily basis is very different from the rest of the population. They also have such a very limited window to actualize a lot of their goals, whether it be on the field or getting an education or realizing some sort of professional opportunity. The opportunity for that, the window for that is very, very tight. And so our primary focus when it comes to patient care is really around recovery and rehabilitation. And that the foundation of that is going to be our understanding of the physical stress theory, where we know that there's a certain level of physical stress that's necessary to induce adaptations. So everybody wants their athletes to be bigger, faster, stronger, more resilient, right? So we need a certain level of stimulus, a certain intensity of stimulus to induce those adaptations. We also need a certain level of stimulus and physical stress to make sure that they maintain those adaptations. But we also know if we do too much, then we introduce injury into the system. If we do too little, there's decreased tolerance and obviously atrophy, which are bad things for us. So our mantra is always going to be movement is medicine. And that's actually a part of the AT residency program in orthopedic rehabilitation that we have here at UTSA. So when we're designing our rehabilitation programs, we try to focus on addressing impairments in the following order. We try to address pain and postural control. We try to address flexibility and range of motion issues, strength endurance, as a base, hypertrophy, maximum strength, power, which will also include our peak power, speed, agility, and quickness, and then address these sports skills that we talked about in our sports performance hierarchy. So exercise we see as our primary tool against pain and dysfunction. However, we use BioWave to help facilitate movement and mitigate the negative responses we have to pain and inflammation we may have to introducing progressive overload to the system. So essentially that creates, in our recovery philosophy, we want to create the space for those adaptations to take place. We want to create the healthy space to introduce dynamic and complex movements into our rehabilitation programs and continue to progressively overload the system without the nociceptive response. So in a treatment session, if you were to come into the athletic training room at UTSA in a typical treatment session, what you'd probably see is some sort of warm-up activity or cardio activity. They'd move into a movement prep phase, where it may be manual therapy or flexibility or neural activation or range of motion or some DNS, which is dynamic neuromuscular stabilization. If appropriate, we'll move into some form of power exercise, strength endurance or strength exercise or activity, some balance and proprioception activity, some agility work and sports skill work as appropriate, increasing complexity, intensity, working on reaction times and activities that have a high neural load. And that's not cookie cutter. That's just generally speaking. Some of these things may change in terms of the order that they're applied to a given program. But generally speaking, if you walk into the athletic training room, you're going to see something in each one of these categories. And at the end, what we want to do, like I said, is kind of mitigate any negative responses we may have to this level of loading. So the last portion is our treatment recovery category. So we typically use BioWave during our treatment and recovery portion of the rehabilitation program because we want to reduce somatic nociception and peripheral neuropathic pain due to injury. We want to mitigate pain response due to the overload, and we want to facilitate movement, reduce the guarding effect, right? Other uses you'll see very commonly in the athletic training room from us will be post-operatively. We'll use it as a major pain management tool to reduce our dependence on narcotics. We'll combine it with several modalities, but in particular, pneumatic compression to make sure we're addressing pain and inflammation or excessive soreness. We'll use it as a recovery modality for acute management of pain after intense exertion, practices, or games. And then we'll also use it as a movement prep modality to reduce pain and the guarding effect and increase active range of motion ahead of either a practice or a game or even a rehab session. So our first example, our first case study, again, we're going from most basic into more complex application. So our most basic application of the technology is just addressing pain. So we have a peripheral neuropathic pain scenario. We have a 20-year-old women's golfer who has a history of low back pain. Our areas of interest during our exam are L3 to L5 and even the SI joint. Previous imaging showed no signs of structural damage to the lumbar spine or the discs or anything like that. Our evaluation basically led us to understand that she had limited thoracic mobility, extension, and rotation. She had limited postural stability during an overhead squat assessment. She had pain with some nerve traction tests, obviously the slump test, and she was positive for a Thomas test showing a limitation in the iliopsoas. So our treatment plan focused on increasing her thoracic spine and hip mobility, increasing postural stability, and obviously reducing the low back pain. So again, when we come up with our treatment plan, our rehabilitation plan, there are going to be a lot of different aspects to that because we not only want to address it in the athletic training room, we want to address it in how we modify or regress the activities or the exercises that they're doing in the weight room or on the field or at practice. So all of that is a part of the communication to the team around how we're going to treat a specific case. So in this case, our rehabilitation plan was obviously first to address the pain, to do some dynamic neuromuscular stability exercises, some DNS exercises to make sure that we're maintaining postural and core stability during movements and addressing any deficits. And then to address sort of the neurodynamics of the sliding with nerve glide and tension exercises to increase mobility. So activity modifications, one of the regressions that we programmed into her strength and conditioning program was a trap bar deadlift or a hex bar squat as a supplement to the barbell squats and some of the Olympic barbell movements that the rest of the group would typically do. And that's just to reduce the amount of lumbar stress while she's dealing with it. And again, in a sport like golf, if somebody has a history of low back issues or any sort of chronic issues like that, we may never reprogram anything other than hex bar modifications or some other modification if we can continue to get the same effect that we want. So how we use BioWave in this system or in this treatment plan is we engage the static pain protocol, standard static pain protocol, and we actually use a new piece of technology that everybody was really excited to use, which was the BioWave BioWrap. So this student athlete, she would come in once a day, do her rehabilitation program. They lifted 2 times a week. And she would come in once a day. And after doing her rehab program or after coming off the course, if it was already a really, really taxing day, we would do a 30-minute treatment with her with the BioWave BioWrap wrapped around her lumbar spine, obviously using the conductive gel before we place it on there and waiting for that to dry, and then allowed her to increase the intensity as high as she could tolerate. We also use it as a recovery modality after long tournaments. And fortunately, after approximately 2 weeks, she showed a substantial decrease in her reported pain. She was able to compete not only in the fall, but also in the spring in all competitions without incident. And then she posted a team and personal best round in our home tournament here in San Antonio at the San Antonio Country Club this spring. So that's a case that went really, really well. That responded really positively to the technology and to the rehabilitation program. And it allowed us to address the issues that she was having without resorting to any sort of heavy pharmacological interventions. So next case, still very common, but a little more complex. We had a football player, cornerback, who was injured his knee, changing direction, came in with some knee pain. Pain had been going on for a few weeks. He had a history of right knee pain, but he had some pain in his left knee now. The pain was located medially and laterally. And then he felt tightness and sometimes felt a popping sensation over the area. The area of interest obviously was the lateral meniscus and the lateral plateau. And it's what we found after an MRI. He was referred for imaging. We found actually a lateral meniscus tear with some referred pain on the medial side. But the actual damage to the tissues was on the lateral side of the meniscus, and a slight sprain of the medial collateral ligament in that left knee. So the treatment plan, we ended up having him undergo a partial lateral meniscectomy. Plan was to have him do the procedure, go through rehab, and use medications as necessary. Primary medication we were using at that time was diclofenac, both orally and topically. So the rehab plan, obviously, first objective was to reduce pain and inflammation with modalities, and then introduce some form of progressive therapeutic exercise. Again, we want to get our primary tool in all of this is movement. We believe firmly that movement is medicine. So increasing in intensity progressively, increasing in movement complexity progressively, and we wanted to try to move early because his goal and obviously a team goal was to get him back on the field of play within 2 weeks. So modifications that we employed, instead of having him run with the team or run with anyone else, we used our anti-gravity treadmill and our hydrotherapy pools to get him moving early. We introduced blood flow restriction therapy as well to reduce the amount of mechanical load while still doing a lot of movements that fit within the movement categories that he would need to do. And so BioWave again became essential. We actually used all three of the units in this case. So post-op, we immediately applied a BioWave home, sent him home immediately with a BioWave. He was instructed to do 2 to 3 treatments a day, 30 minutes with one small electrode and one disperser pad. When he came in for rehab, he would use the BioWave Pro for his treatment recovery, one treatment post-rehab and one recovery post-lift or practice if needed. If we had the time and the opportunity with schedules and the rest, we would apply that as well. And then the last way we would use is the BioWave Go. Again, it was an adaptive technology that allowed us to pack light while still performing the same treatments that we would do at home. So we use the BioWave Go post-game for pain and swelling, either on buses or on planes or wherever we were going. So outcomes, this injury actually happened during the preseason, and he was able to play in our first game, which was a huge game. We actually upset the team. I won't say which in case we have some alums listening to this lecture, but we actually upset the team that we played. And he unfortunately had a re-aggravation about 5 weeks post-op that we had to address with an injection and rehabilitation and modalities, but he was able to recover from that as well and competed and started the remainder of the season and can continue to be a major contributor on the team. The last one is the most complex because we actually have two injuries that we're going to cover. So we had a 20-year-old female softball player who was a shortstop. During the preseason, she complained of some bilateral anterior hip pain during the evaluation, and she was 2 out of 10 without activity and a 5 out of 10 with activity. While range of motion was within normal limits and there was no edema, ecchymosis, or deformity, it became clear that she was suffering from snapping hip syndrome. She even described the experience of feeling both hips snap and right over the pectineal eminence. So the treatment plan for her was to try to reduce her pain, increase dynamic neuromuscular stability, and then increase her hip mobility on top of that. So she was doing well. So our rehab plan was very similar. We did a lot of hip mobility stuff, did a lot of DNS with her, used BioWave. We had 2 units on her because it was bilateral. We used 2 units with 2 small electrodes on each side, and sometimes a disperser pad as well that cover a larger treatment area. We would do that for 30 minutes. She would do 2 sessions a day, post-rehab and post-practice for recovery. And she had a pretty positive outcome up until she had another incident where she developed patella tendonitis. So about mid-season in the spring, she started complaining of some pain in her left knee. Without activity, she didn't really have any pain, but with activity, she was complaining again of about a 5 out of 10. Range of motion was within normal limits, but she had pain with squatting and eccentric knee flexion. No edema, no ecchymosis, no deformity, but it was obvious that she was suffering from patella tendinopathy and likely patella tendonitis. Our treatment plan, again, was to reduce pain, increase her dynamic neuromuscular stability because we still wanted to make sure we were tackling the issues she was having in her hip, increase eccentric control and stability of the hip and knee, and improve her overall strength in her lower quarter. So our rehab plan was, you're going to do all the things that you've been doing, plus we're going to add a bunch of other things as well that address this other issue that you're having. So we continued the hip mobility and DNS. We added BFR with eccentric loading to her rehabilitation program, a ton of corrective exercise and muscle re-education to get that eccentric control back and improve neuromuscular efficiency. And again, because we now have three sites of pain, obviously the first had improved significantly, but we now have 3 sites of pain. We want to, one of our major goals is pain modulation as a part of movement prep and recovery. So this is the one where we actually used it pre-activity quite a bit. So again, the static pain treatment protocol is what our athletic trainer ended up using. She would do during her movement prep, pre-practice, or even prior to games, she would use heat and the BioWave Pro for at least 10 minutes. And then post-practice or post-rehab or post-game, she would use the BioWave Go, either on the bus or somewhere else, combined with some pneumatic compression recovery boots for about 20 to 30 minutes, actually. But again, this is an athlete that had a pretty positive outcome at the end of all of this. She played the entire season, was able to be a major contributor, and she had reduced and tolerable pain with activity. And even the AT and the student athlete credited the BioWave technology with her positive outcome. So in summary, again, BioWave is a perfect fit for the fast-paced and demanding environment of elite athletes. It's effective, like I said, initially in addressing both somatic nociceptive pain and peripheral neuropathic pain, which is what we usually use it for. It's efficient. It's simply operated and applied quickly by any clinician or even a patient at the end of the day. And then it's adaptive. It can be used in a multitude of circumstances, environments, and scenarios so that we can easily apply it, efficiently apply it, and use it for any number of our patients who are experiencing pain as a result of injury. So I'm looking forward to any questions that you may have specifically about our usage of the technology or anything else that you want to know about how we use it at UTSA or in the high performance sport environment.
Dan, thank you very much. That was a great presentation. We have several questions that are coming in. So the first question that came in is, would BioWave be a good tool to use in alleviating low back pain / deep glute pain as a result of FAI? I believe that's femoroacetabular impingement
Yep.
in athletes with history of playing ice hockey? And if so, what other treatments would you pair it with?
That's a great question. I think I'll start off by saying any time that we have any sort of pain syndrome, whether it's directly attributable to acute tissue damage or any sort of central or peripheral, pain sensitization, I think the peripheral nerve electrical stimulation that BioWave provides, I think, can be really, really helpful. And so I would use this, and as a question was being read, I was thinking we'd probably use it multiple sessions a day if possible, sort of a compounded effect. I think what is also very, very important to consider, again, is what are the other deficiencies, what are the other issues that we need to correct? What are there postural issues that we need to correct? Are there neuromuscular deficiencies? Are there any other deficits that we need to address? So obviously you want to go through and address those first through your therapeutic exercise, because at the end of the day, exercise has a pain relieving effect, and we use that to address nociception as well. And you ultimately want functional movement for that person, and you want them to return to the activities that they enjoy. What I would think to pair with those on top of the multiple treatments a day and even 30-minute sessions a day, is if you could do a dynamic pain protocol, which is sort of the pre-activity pain protocol to help mitigate pain and kind of free up motion before a rehab session. We love pairing therapeutic exercise, especially when we don't have a great tolerance for mechanical load. We like to pair that with blood flow restriction therapy and any other sort of load modifications that you can add, whether that's a reduced load with hydrotherapy in the pool or with a anti-gravity treadmill as well. I think those are things that are great complements. Pneumatic compression is one of our primary complements to the BioWave technology that we like to layer on because it helps reduce the inflammatory response. But BioWave also has a increased vascularization response as well, so that can be helpful, especially if you're working on an acute injury. So I think those are some things that I would layer on, but not ignoring any of the other postural corrections that you have to make to really address the fundamental issues there.
Thanks, Dan. There's several more questions. One question came in is, you mentioned the BioWrap in your first case study. What is the BioWrap and what are its benefits? Let me take a first stab at that, and please feel free to add anything after. A BioWrap is a compression a wearable compression electrode garment. They're designed for different parts of the body. The one that Dan was talking about was our back BioWrap. The big advantage of this device is that it has built-in silver fabric electrodes that allow you to treat up to 5 times the area as compared to a conventional 2-inch round electrode. So on the back, you're treating the entire lumbar area. And we have BioWraps available also right now for the knee and for the foot ankle. So you just can capture it on the knee. It's anterior and lateral medial placement of these large silver electrodes. You're capturing the majority of the knee. And on the foot ankle, you've got a circumferential electrode just above the ankle and a circumferential electrode around the entire foot. So you can stimulate the entire ankle and foot from above the ankle down all the way to the toes. And, so if you have an athlete with a high ankle sprain, the foot ankle BioWrap might be a really good application. I know, Dan, do you want to add anything else to that from how you use it in your athletic training room there?
No, that's precisely how we use it. The BioWrap technology just allowed us to cover a much larger surface area because the pain was generalized. I think again in the presentation I talked about the area of interest being L3 to L5 with some SI joint pain. So that's a significant amount of area to try to address. And the BioWrap is essentially looks like the sort of back braces that we put on some of our patients as well. It's just has the electrodes towards the back, the large electrodes towards the back, and it has a conductive gel that increases the amount of treatment area as well. And that's how we use that. That's how we use it in that case, and that's how we continue to use it with any of the other BioWrap technology that they put out.
Thanks. I'd also mention that the BioWraps are providing compression simultaneously while they allow the delivery of our high frequency neurostimulation into deep tissue. Another question here is, would BioWave be a good treatment for a male soccer player with Osgood Schlatters, and how would you administer treatment?
Yeah, another good question. I would say with Osgood Schlatters, because your pain is going to be more focused and localized, we would use the smaller electrode pads on the actual site of pain. And if this is somebody who's fairly acute and has significant pain right now in the moment, we would use that as a movement prep exercise as well, to allow us to later go on and do some of that eccentric loading and postural and eccentric control correction that we need to do. And then we'd follow that up with another treatment of the same, probably around, because the dynamic treatment is around 10 minutes. The static treatment is around 30. And it's a very easy technology to apply because we can put it in the hands of our athletes and not be concerned that they're going to mess it up or break it. So we can have that student athlete really place that intensity to tolerance and leave them there for about 30 minutes, throw on some more pneumatic compression again to address some of the inflammatory response, do the progressive loading on that tendon and those tissues, and be confident that they're going to have a measurable effect for at least the next few hours, and then a cumulative effect that's going to continue to improve their pain experience over the next several weeks.
Thanks, Dan. Next question has to do with the duration of pain relief following a treatment. What's the duration of time post-treatment that you see your athletes are getting in terms of pain relief?
I think the effect is both acute and, like I said, cumulative. So acutely, for somebody who, let's just say, again, maybe they don't have tissue damage, they just have a sort of peripheral nerve pain syndrome, right? That we're trying to address. In those scenarios, and even in some of the somatic neuropathic pain scenarios where we have actual tissue damage, in a single treatment, we can see a reduction in pain and sometimes an alleviation of pain for the next few hours. We're obviously going to follow that up with some form of, especially acutely, some form of pharmacological intervention, some medication to send them home with to, compound that effect and make sure that they're not in pain later. But really what we see is in repeated treatments, particularly post-operatively, we're able to sort of wean our student athletes off of their post-op prescriptions fairly early and get them moving fairly early without pain. And I think that's one of the major benefits, is because we realize that they're a necessity after a procedure, but we want to try to progressively get them off of those medications and not produce a dependence on those medications for movement and activity. And BioWave allows us over time to create that space for them to reduce their dependence on that.
Thanks, Dan. There was one more question. Have you noticed a change in the amount of time it takes to heal the injured area when you're using BioWave on a regular continued basis?
I think that, to be honest, that's kind of a hard one to answer, because we haven't run sort of a control group that was only BioWave and then another group that didn't do BioWave, or a control group that did just BioWave and this other group did BioWave plus some of the other modalities that we like to layer on there. I think generally speaking, so a lot of our, especially a case like our football athlete who was able to return before our first game, even though he was injured and had surgery during camp, we see an increased tolerance, not an increased tolerance, but a reduction in pain that makes a lot of activity very much tolerable. And when we've used it on some of our soft tissue injuries, we see an increase in activity fairly early. Now, whether we could see that under ultrasound and we could see an increase in tissue density, or creating muscle and things like that, I can't say for sure, but I can say that it increases our ability to apply functional movement to our athletes fairly early on in the healing process, without recurrent injury. Thanks. So without a control, it's a little difficult to say whether there's a faster recovery with BioWave or without recovery. But I can say, just based on the science behind the technology, that an increase in blood flow and capillarization, an increase in a reduction in pain is going to help with the healing process.
So I guess you could say empirically you're seeing some positive results that show that there may be a benefit in terms of its healing capability.
Absolutely.
And I think obviously it's not controlled at all.
Yeah,
so.
Right.
There's another question just came up about how many units do you have for the amount of student athletes you service?
That's a great logistics question. And so that's really actually hard to tell, because what we've gotten to the habit of doing, because we send our post-ops home with a BioWave unit, we've gotten into the practice of using our claims administrator and our intercollegiate sports insurance policy to make sure that as one of the modalities that they're sent home with, whether that's a game ready or something else, that BioWave is a part of that post-op modality package, I guess you could say. So at this point, we have about 16 treatment tables in the athletic training room. So let me back up. We service about 350 student athletes. We have 2 satellite athletic training rooms and 1 primary athletic training room that we just opened up. New building we opened up in the fall of 2021, actually, this past fall. And each of our treatment tables has a BioWave underneath them. And we have probably 6 or so BioWave Go's that are also on standby as well. So again, any student athlete who is going through through a procedure, and we want to make sure that they have both a modality to reduce their inflammation and to control their pain post-operatively, we use that. We prescribe them one of those as a part of their post-op package, and then we use those in the athletic training room moving forward to treat any sort of pain syndrome that walks through the door.
Great, thanks, Dan. That's all the questions right now. If anybody out there has any additional questions, please let us know. We'll give you a little bit to send it in. Otherwise, I think we're all set. Dan, thank you very, very much for your time. I thought it was a great lecture, and To all the participants, thank you very much for attending. Please look out for our next webinar